Assalamu alaikum everyone. We're going to talk about cardiac tamponade in this video. So let's start. Bismillah. Cardiac tamponade, first of all, let's talk about the name. Tamponade comes from the word tampon. And as we all know, tampons are things that are used to soak up blood, right? So in this case, tamponade also refers to something that soaks up blood. What is this thing in this case? It's the pericardial sac, unfortunately. So let's say anatomically that this is the heart, for example, and this is the pericardial sac. On an average individual, this pericardial sac has about 50 milliliter of fluid released and reabsorbed by the pericardial sac serous cells, right? So it remains in this range, give or take. This fluid is very important because it reduces the friction during contraction and relaxation. It allows a more fluid movement of the heart. Pun absolutely intended. However, in the tamponade, what happens is this pericardial sac inflates to about this big, right? So you have this entire space being filled with fluid. Now the fluid can be blood, pus, what have you, right? And as we all know, fluid has a force. So it pushes against the heart. It pushes against it from every direction, compressing and restricting its movement. So now you have the heart being unable to fill enough, to fill properly, unable to contract properly, unable to relax properly, and like everything مسوي له زحمة بالعربي. This fluid crowding the space for the heart to move freely. And when the heart can't move freely, can't fill in properly, it cannot put out properly. So the cardiac output will decrease. And this right here is the reason for all the signs and symptoms that we will talk about later. Less cardiac output. Now the problem here with the tamponade is that if this effusion continued, it might lead to no pumping at all. So you will not only have less cardiac output, you might not have any output at all. And if you have no output, it means you have no pulse. And if you have no pulse, it means you have no oxygen. And if you have no oxygen, you are dead. And this is the reason why cardiac tamponade is a medical emergency. It's a big deal. However, it's an emergency only in the acute setting. If it's chronic, it's a little less urgent. How, you ask? I'll tell you. So in the acute setting, it's usually caused by a damage. What kind of damage? Trauma. What kind of trauma? It can be blunt, like in a motor vehicle accident, for example. It can be penetrating, like stab wound. It can be surgery, like cabbage, right? Or any sort of open heart surgery. It can also be due to a heart attack, myocardial infarction. Those dead cells can lead to pericarditis, and pericarditis can lead to pericardial effusion. And pericardial effusion might then lead to tamponade in case of heart attack. In the chronic setting, it is usually caused by a disease. What kind of disease? Like I just said, pericarditis. It can be caused idiopathically or by a virus. Like it has many other causes. It can be caused by connective tissue disorders like Marfan syndrome, for example. It can be caused by cancer. This is actually, like, unfortunately pretty common in cancer patients. Renal failure, less common, but it happens due to increase in urea in the blood. Medication can lead to this. Also, autoimmune diseases. Autoimmune diseases can be like lupus, arthritis. It can also be HIV. All of these things can lead to cardiac tamponade. However, why did I say this is an emergency? why did I say this is an emergency and this is not an emergency? In the chronic situation, it's chronic, meaning it happens over time. So it happens over time in a long period of time that allows the heart to adjust. It allows the heart to work with the new environment and adapt. So if you give the heart a long time or an adequate amount of time for it to compensate, it will work with you. However, if you come up and suddenly start dumping fluid around the heart for no apparent reason, it will be shocked, and it might even be stunned into silence and stop working. That is why you don't want the acute. Acute is emergency, but chronic is not. However, in both cases, the fluid will need to be drained, but I'm just saying, like, in the clinical setting, one is an emergency and one is not so emergent. Another thing that I need to clarify or make clear right now is that pericardial effusion, pericarditis, and cardiac tamponade are not the same thing. They're not interchangeable terms. They're not used or mean the same thing. Cardiac tamponade and cardiac tamponade, on the other hand, actually mean the same thing. They're the same thing. But pericardial effusion, pericarditis, and cardiac tamponade are not the same thing. They're actually a sequence of events. So it starts with pericarditis, can lead to pericardial effusion, which might lead to tamponade. In other words, tamponade can be caused by pericardial effusion or is caused by pericardial effusion. In other words, every tamponade is caused by pericardial effusion, but not every pericardial effusion will lead to tamponade. Because, like I just said, in the chronic, for example, in cancer patients, in most cases, you will see them having pericardial effusion that they learn to live with, or their heart learn to compensate for, right? So they won't be having those kinds of signs and symptoms of the tamponade. So again, every tamponade is caused by a pericardial effusion, but not every pericardial effusion will lead to tamponade. Same thing for pericarditis. It may or may not lead to pericardial effusion, which may or may not lead to tamponade. Right? Okay. Now let's look at the signs and symptoms. The signs and symptoms of cardiac tamponade can be categorized into three main categories: hypoxemia, Beck's triad, and the pulses paradoxic. So the hypoxemia is low oxygen saturation in the blood due to the low cardiac output, less blood, less oxygen, okay? So the first sign of less oxygen saturation is tachycardia. Why? Because, as we know, cardiac output equals the stroke volume times the heart rate. So if you have a low stroke volume due to low cardiac output, or if you have a cardiac output caused by low stroke volume, because if it has no space to fill in, it cannot put out, like the stroke volume will be less. The heart will try to increase the heart rate to compensate for the output, right? Leading to tachycardia. It won't do nothing. It will be futile, but it will happen. Another sign of low oxygen is altered level of consciousness. The patient will be confused and maybe disoriented. If the hypoperfusion is in the brain or reaches the brain, you will have syncope. If it continues, it might even lead to shortness of breath. Why? Because the body will think that, okay, maybe there's a problem in the oxygen supply from outside, so let's have you breathing in more rapidly. So what happens is you will have shortness of breath. You will try to breathe more, but it will be futile, and the only thing this will do is increase your heart rate, leading to tachycardia, and you will now have a cycle. The other thing is the Beck's triad. Beck's triad are important for exams. So Beck's triad is jugular venous distension, hypotension, and muffled heart sound. These things actually make perfect sense. Like imagine if you have, say, an alarm clock, okay? And you submerge this alarm clock underwater. You will still hear the alarm going off. It's just the sound will be muffled because the sound will have to travel across water to reach your ear. So that's why. Same thing with the heart. Hypotension, because like we said, low cardiac output means low blood pressure. Jugular venous distension, because this is your right atrium, right? Your right atrium has been, or every chamber in your body has been compressed because of the fluid, right? So it won't be able to fill with as much blood as it usually does. So the blood will kind of just hang in your veins, right? So you will not only have distension of the jugular vein, but even your forehead veins will be distended. Like it's not pretty. Pulsus paradoxus is a normal phenomenon in most cases. Like in every normal individual, during inspiration, your systolic blood pressure will drop. However, in normal cases, it will be less than 10 millimeter mercury. In the tamponade case, the systolic blood pressure will drop more than 10 millimeter mercury on inspiration. Why is that? I'll try to explain it as much as I can. So like I said, every chamber will be smaller, okay? Every chamber will be smaller. So the right atrium will still fill with blood from the inferior and superior vena cava. It will try to push it down to the right ventricle, but it still won't be able to push everything. So the only thing that the right heart can do is push against the left heart, against the septum. This will cause an even more of restriction or constriction of the left heart. So now the left heart will only have this much space to fill. And if it has less space to fill, it has less blood to put out, right? So this leads to less blood pressure. That's why the systolic drop is more than 10 millimeter mercury. For example, if an average individual, say during inspiration, their blood pressure drops from 120/80 to 110/80. In case of tamponade, it may fall to like 90/80. Okay, that's why we say hypotension. So the blood pressure is low everywhere. Hypotension systematically and systolically, centrally, right? Now let's talk about investigation. In the investigation of tamponade, unfortunately, there is not one single criteria that is fits all. Like one thing fits all. No, it doesn't work like this around here. Here you will have to look at everything. So in the history, you will have to look for risk factors. Does this person have pericarditis? Do they have cancer? Is there renal failure? What kind of trauma are they coming for? You have to look at the B symptoms, fever, night sweats, weight loss, right? Because it can indicate TB, and it can also indicate some kind of viral infection. You have to ask about surgery, especially cardiovascular surgery, right? So cabbage, you want to ask about any kind of bypass surgery and any kind of open heart surgery, because in most cases, these will lead to tamponade. So you have to be careful with that. On physical examination, you want to look at the precordial pain. Precordial pain refers to the shoulder and neck, but that's not important. The important thing in precordial pain is how it looks. So if you have this patient, your patient will be sitting up. This is their head, okay, and these are their feet. Your patient will be sitting up and leaning forward. Why is that? Because if they lie down, then the pericardial sac will be extended even more. And it's already distended beyond its capacity. So if you extend it even more, it will hurt like the blazes. They won't be able to tolerate the pain, so they will sit up and lean forward. In this situation, they're trying to compress it as much as possible to try to relieve the pain as much as possible. So this is what precordial pain looks like. In the diagnostic tests, we have the echo and MRI. Both of these will show you, visualize the actual effusion. MRI will be an image and echo will be in real time. This is the difference. Echo is preferred, but it's not the gold standard. Here, there is no one gold standard. On ECG, you will see something that is called electrical alternans, and on chest X-ray, you will see cardiomegaly. I'll show you. So this is an ECG, and if you look here at these, do you see? You see how this is a tall QRS and this is a short QRS? So you will have short as well as tall QRS waves. This is what alternans means. It means just it alternates. The electrical impulses will alternate between long and short ones. Long one, short one, long one, short one, long one, short one. Do you see that? And look at this. Look how big it is, mashallah. Cardiomegaly. For the management, you have to drain the fluid. This is the one thing that you will have to do. How do you drain it? With pericardiocentesis. In this procedure, you insert a needle beneath the xiphoid process or between the 5th and 6th ribs, intercostal space, like Dr. Malak said, and drain the fluid. Then send the fluid up for analysis. Why? Because cardiac tamponade, by and large, doesn't just happen. There must be a cause, and you have to treat the underlying cause. So if it's pericarditis, you will have to give the patient aspirin and NSAIDs. Conversely, I have to make a note here. During chest pain, if a patient comes in with chest pain, you give them aspirin. Chest pain, aspirin. This is like a rule of thumb. However, if they already are on aspirin, then you might give them other type of NSAID to control their pain and inflammation. In case of acute or relapsing pericarditis, you might want to consider colchicine. In case of severe rheumatic carditis or post-pericardiotomy, what is pericardiotomy? It's the same thing we talked about earlier, the surgery, cabbage, open heart surgery, what have you. In these cases, you want to give steroids. So not NSAIDs, just STEDs, steroids, corticosteroids. In case of purulent pericarditis, that is pus, if there is pus involved, then you give antibiotics. You have to give antibiotics in case of pus. You don't want to give digoxin because digoxin blocks the tachycardia, and you want to allow the tachycardia. You want the heart to try and pump out as much blood as possible, even if that entails tachycardia. Let them be. Let the body work itself out. If you take the fluid out, let the body works itself out, okay? This is all.